to go into a very important topic. We are talking about totality of everything. So there is no totality without psychosocial issues. So a warm welcome to Mr. Sarath, who is a social officer and an active member of the Palim India Trivandrum. He has obtained his qualification and specialized in important aspect, which is community development. We need community development to be successful in anything. So, and also his main interests are home-based palliative care and pediatric palliative care. A warm welcome to Mr. Sarath to enlighten us on social issues in palliative care.
Thank you, ma'am. Thank you so much for the warm welcome. So, hello everyone. So this is Sharath K. It's not Sarath, it's Sharath actually. Okay. Today I'm going to take a small session about psychosocial aspects of care, because I know you all are doctors and you are very much have a good knowledge in physical care. So the next phase is psychosocial care. So this is where I get more experienced from Palim India, and I pursued MSW with community development. So I get to know about the community and what services we can provide with the help of psychosocial care. So let us get through it. So I'll just sharing my screen. Okay. So psychosocial aspects of care. So in this session, we'll be going through what is total pain, social diagnosis, assessment, not the clinical assessment, the psychosocial assessment, genogram, ecogram, and plan of care. And at the end of this session, you'll get to know about what are these terms in psychosocial care. Okay. So starting with this is a small depiction about palliative care by none other than WHO. So you can read it from here. Like palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems like physical, psychosocial, and spiritual. So this is a basic one you'll get in the internet, depicted by WHO. So in this first point, the main word I will tell you is the quality of life. So that is what we focus on everything, like to improve the quality of life is a main aim of palliative care. So we'll be going through several sections. So if you have any doubts or any clarification needed, you can just pin it in the chat box. Okay. So I'll just introduce you with a case. So we'll be going through the whole session with this base because this is an example of an example case. Okay. So you can go through this like here. There is a 56-year-old lady, Mrs. A, has been diagnosed with CA breast in 2016, and she had undergone mastectomy and then referred for pain management. She looked very anxious and had no idea about palliative care, comorbidities, diabetic since 12 years, coronary artery disease, fracture on leg due to fall in 2019. And she is a widow, and her children are having a hostile relationship with her and lives alone in her house. So just take it in your mind that this is the case, and we'll be going through this session in accordance to this because this is the base for this. Okay, so we have a good idea. Okay, so we'll just go with our session. Okay, keep this in your mind. That's the only thing. Okay, so why is psychosocial care important in palliative care? Psychosocial care means like a person who is living with a life-limiting or life-threatening illness, or the awareness of approaching death causes unique stressors and challenges. We know that every person is having so much problems, but until when they realizes or they get diagnosed with any other diseases, they'll be having there will be no other problems affecting them. The main problem will be the disease and the stress surrounding to that disease. So that is where psychosocial care is very important, because we have to consider the patient as a whole person. And the serious illness disrupts individual thoughts, feelings, relationships, and social, spiritual supports, financial stability, and spirituality. So these all things are connected with a patient's disease. So this is why a psychosocial care is very important. So as I mentioned in the first slide, total pain. The illness-related suffering is much more than just physical distress, because you know that physical things you can just have a quick note about that with a case study. Like she'll be having so much physical problems, you can diagnose it and you can have medications for that. And when you compare where or mm, when you think about in a big scenario, it will come like total pain is not only physical, it is actually related with psychological problems, socioeconomic problems, and spiritual problems. So these four things are interrelated with one another, and it will lead us to total pain. Okay. So this is total pain. So you'll get a brief idea about how a total pain can be assessed and how it can be. It will not be cured. It can be decreased by a huge margin. Okay. So the basic thing will be assessment. In psychosocial care, what we do is we'll just get more information from the patient or the proxy or the patient who's a caregiver or or a person who comes along with the patient. So this is where assessment is very important. So an exploration process of gathering information about the person who comes to us is an assessment. And the interventions or goals that we are going to select mainly depend upon the assessment. So what we assess is very important, because at the early stages of diagnosis or at the early stage of that disease, uh, what we assess will be different in the later stages. So we have to just repeat it, like in a time interval, we have to do more assessment for the patient. So assessment is the basic thing, and uh, it aim it aims at the well-being of patients and their family. And it is used to identify problem areas which result from illness and may influence the well-being. And it also involves in collecting information, identifying and honoring strengths and resources and needs. Because every person have their own priorities and their own sufferings. So each person is different from one another. So if you consider me as a patient, or you can consider the patient, which we are like Mrs. A. So she is having so much problems. At the very first stage, we don't know what exactly happened in the house or what she is exactly going through. So during an assessment only, or with the help of an assessment only, we can go through what she is facing and what are their strengths, what are the resources we can get it from her surroundings, and what is her exact needs. This can be assessed. So with the help of that only, we can plan a care plan. Okay. So assessment is very basic and it is an ongoing process. As I said earlier, it is an ongoing process as the psychosocial needs of patients and family or caregivers often change over the course of illness. I want to share one example of a patient who came to our OP. At the first stages of registration, it was like she's having severe pain. And we just, our doctors had a clinical assessment. And after that, they opted for tablets like morphine and everything. And after several days, she's still saying that I have pain. I don't get any kind of relaxation with the medicine, what you're given. Then they are referred to us, like to take care of like a psychosocial aspect. We have to check whether she is able to continue her medications, or is she able to just go through the family situation is going well or not. So these kind of things we came across, and we just had a home visit to the patient. And on the visit to the patient, we get to know that she's not getting any kind of help from her family members or any other persons surrounded by her. So this was the thing, and she had two children, and this made her feel that the stress related to their studies, the children's studies, and the problems surrounded by her, like make her more painful. Sorry. So this was the exact reason for the patient to not decreasing the pain. So often what comes is when a patient comes to us first, and they will deliberately say that we have pain, it will not be the physical pain. It will related to their other things like family problems or any other social problems too. One second. Okay, sorry. The next one will be purposeful observations and purposeful conversations are needed to assess the exact problems. So we'll go to the first one. Like we'll think about the case, what I said in the previous slides, like Mrs. A, about Mrs. A, the patient who suffered with breast cancer. So I have mentioned you like she is living alone in her house, and her children are not very supportive. So this is the way to that patient's home. You can see that there's a stone paved path. It's not very normal one. It's a steep one. So the next one is the house of that patient. So where you can see it's not very good. And during the rainy season, it gets poured. And these are the source of information that we collect information. Like these home visits made us get to know more about what is her current situation. So the source of information will be like first one will be the patient or the caregiver who comes to the OP or the institution. Then the next one will be collateral source, like friends, relatives, neighbors, etc. And the third one, this is an important one, like home visits. With the help of home visits only, we can know what they are going through exactly. So this will help you to know more about the person and their surroundings. Okay. So the next one will be assessments parts. Like what are the parts to be assessed? So the first one is patient overview. Second is insight. Third one is family overview. Next, socio-economic overview, psychological overview, spiritual overview, and then comes interventions and plan. So we will go through every points. So the first one is patient overview. So it's very basic, like the name, age, gender, the diagnosis comes under patient overview. Where you have to just note what are their current diagnosis, exactly what is their diagnosis, then their basic details only. So then comes insight. Is they aware about their illness, current illness, or is they having any kind of problems regarding pollution or something? Then what are they inside about palliative care? Is they know about palliative care? What is palliative care? So this kind of information can be gathered in the section of insight. And then if they don't know anything about palliative care or about illness, if needed only, we can deliberate, like we can say every details about palliative care, but we cannot explain the consequences of the illness at the very first stages. So if needed only, we can explain. So that is comes under insight. So the next one will be family overview. So first one is genogram. We'll go through that. And second one is primary caregiver. We all know that every family has a primary caregiver or primary caregivers. And like everyone is sufficient now to take care of their family on their own. So who is the primary breadwinner for the family? So that's needed to be checked. Then the support system, if they're getting any help from society or any other friends or something. Then what is the structure of the family? That structure can be can get from the genogram. Then the nature of relationships. So if they're having any conflictual relationship with any family members or something, then we can know about it with the help of this. And these all points that is written below the genogram is related with the genogram actually. So every details can be, this form family overview can be get with the help of a genogram. So we'll be going through our next one is genogram. So if you have any doubts or something, feel free to ask, okay, through the chat. So next one is genogram. This is a basic family overview where we can get all the information. So basic symbols are male and female, like a square and a circle. Okay. So the next one is the relationships. How can we represent their relationships? If a straight line is drawn, it means a married person. If there is a cross, a one cross is there, then it means a separated relationship. If there is two lines, then you can say that the person is divorced or legally separated. Then the next one will be if it's about children and birth symbols. If a family is there, they'll be having children. In some cases, there will be no children. So in the case of children, if there is children, this is the basic symbol. The first one is the basic one. Sorry. Biological child. So there will be no much drama. If it is a baby girl, then it will be a circle. If it is a boy, then it will be a square. And the next one is the dotted blue lines means adopted child. Then if there is a foster child is there, then it will be noted by small dots of green lines. Then if there is a pregnancy there, then you can depict it with the triangle. Then the next one will be miscarriage. A cross line is drawn. Then the next one is abortion. The next one is male stillbirth and female stillbirth. So these are the children and birth symbols. So the next is twins and triplets. It's also very basic ones. Like if there are fraternal twins, then you can draw it like two lines in the same one. So then if there are identical twins, then you can connect both the childrens with a line. Then if there is a triplet, then you can extend it. If there is a triplet with a female stillbirth, then you can make it in a circle and cross it. Every time a cross in a genogram means that the person is expired, means passed away. Okay. So next one will be emotional relationships. So this is an important thing because we don't know, with the help of this only, we can know what is going through that family. So plain or normal line means it's a normal relationship. There is no very problems are there. There is everything is going very fine. Then the next one will be friendship or close relationships. So these dotted green lines means there is a close relationship with the two individuals. Then if there is an intimacy or very close relationship, then you can draw it with two green straight lines. Then a hostile or conflictual relation. You can see that a red line always gives you the feeling of like it's a conflict it's going on in the family. So if there is a hostile or conflictual relationship, then a zigzag line with a red color will be denoted. And then comes very closely driven zigzag lines. That means there is a violence or any uh, like conflicts or anything happened in between that persons. So these are the basic emotional relationships. Then we come to the next three ones. The first one is the emotional abuse. It is depicted in the blue lines, blue zigzag lines. So that means one individual is emotionally abusing another individual. So any kind of attitude or behavior change just leads to another person's mental stress or something. We can we can draw with this. Okay. Then the next one is sexual abuse. So where we can draw two zigzag lines, both are blue lines. That means there is a sexual abuse happened in that family between the two persons. So the last one is neglect or abuse. And there is an arrow, it depicts that what happened means the victim. Who is the victim? That means there will be an arrow towards that person. So these are the basic genogram symbols. Okay, if you have anything to ask, just ask in between, no problem. Okay, so these are the basic symbols we use in a genogram, and these are the relationship symbols also. So, as I said earlier, we were talking about Miss A. So you can see a rounded line, a rounded outer line written means drawn in Mrs. A's circle. So that means that is the only family member in that family. So her husband passed away. She has two children. She's having a conflictual relationship, both the children, means a conflictual relationship with both the child. So Mr. C and Miss D are both the children, and she's also having a hostile relationship with Mrs. B. She is the she is her brother's wife. So this is the exact genogram of Mrs. A. So with the help of this, we can get a detailed information about the family. Okay. So anyone have any doubts about genogram? Okay, then we'll move on to the next one. Next one is EcoMap. So EcoMap means it is first introduced by Anne Hartman. That means the pictorial representation that helps to visualize social and personal relationship of individuals with the environment and with the larger society. We know that human being is a social animal. So we are related with the society and other persons. So if there is any conflicts between the society and the person or the deceased person is there, then we have to refer it. Because sometimes it will be in the family or it will be outside of the family. So the largest societal problems are depicted with the help of an equipment. And it is also a snapshot view of important interactions of patient family with other systems like groups, individuals, extended family, organization or association, etc. So in next slide, we can see that a family unit is always surrounded by so much things. Like if you consider me as a person, I have a relationship with my neighbors, my workplace, government services. If I'm availing anything, then the community services, religious institutions, friends, clubs, school, volunteers. Like this, every person or every family is connected with the system. So when we come into our case, the first case, then it will be like Mrs. A is getting help from public health center, church. You can see the arrow that points towards her. So she's getting help from church and she's getting help from palliative care. And there is a dotted line that leads to neighbors. That means she's having a hostile relationship with them. And the next one will be panchayat. So they are connected in a way, but they don't get enough support from them. Okay, so this is an example of ectomap. So the next one will be, we just gone through patient overview. The next one is socioeconomic overview. In every family, we know that there will be a breadwinner. So we have to assess who is the current breadwinner of the family. Then the next one will be, the important one will be, if they get any adequate food, clothing, and shelter. In our patient's case, the shelter is not very usable. Like they have problems with the shelter. It's not very modified. So it's, we can say that it's not that good. So she needs help to improve that thing. So that's the thing we have to recognize in socioeconomic overview. Then other sources of income, if in some cases there will be like cattle rearing, goat rearing, or having some farming or something. So we have to check whether they get any kind of help from other sources of income, or if they get any help from other friends or family members. Then next one is community support. In Kerala, oftenly we heard that we have a community support system, a government palliative care services there, and also there are a lot of NGOs who are helping. So we have to check whether, like in this case also, we have church and a palliative care is supporting, and also the medical center also supporting them. So we have to check whether they get any kind of benefits from others. If they are getting anything, then we have to check whether it is sufficient or not. Then the next one is government schemes. It is a vast topic. Like in here, we get we have a lot of government schemes for the patients. Like there are specific schemes for patients, specific schemes for caregivers, and specific schemes for other family members. If you're a person who is above 60, then you'll get old age pension. If you're a widow, then you get widow pension. And if you're having a serious illness, then you'll be getting the disability pension, or the caregiver who is taking care of the patient is getting caregiver pension also. So there are several government schemes. We have to check whether they are getting anything or they are aware of that government schemes. If they are not aware of, we have to educate them. So that's a basic thing for that. Okay. And next one is ration card. In Kerala, we have 3 or 4 types of ration cards according to their family status, like economic status. So the yellow color means very poor category. Then we have white, and we have pink color and blue one also. So that means according to their economic levels, they are categorized. Then debt. if they have any kind of debts for them, like if they taken any taken money for their treatment or something, or for just having or they have taken any money for their house modification or anything. So we have to check whether if it is there or not. Then other financial vulnerabilities like debt from any other person, or lending money from other institution or something. So this is the socio-economic overview. Then the next one will be psychological overview and spiritual overview. In psychological overview, the first one will be psychological distress related to the disease. Then the emotional support, if they are getting any emotional support from the family or not. Then anticipatory grief. If a person knows about a disease, um, it not only depends on the current situation, they'll be thinking about what comes next. So there will be an anticipatory grief for them. So that needed to be checked. If they know about it, if they will be having some misconceptions, so we have to rectify it. So in this case, there will be she'll be thinking about, the person will be thinking about what happens next. So if it is breast cancer, then how it can be like overcome, or what I should do. So these kind of things come into that person's mind. So we have to just check whether if it is there or not. If it is there, then we have to educate her with our expertise. Then coping mechanism. How is she coping with that situation? She's having that problem also. Then her family is not supportive. So how she is coping with that? So we have to check that. Then the depression or anxiety. Like no one is there to help her, and anxiety issues are there. So what happens next? So these are the things we have to check in psychological overview. The next one is a last one actually, spiritual overview. So how she is connected with a spiritual person or a god or an institution. So then what she thinks about the meaning of life. And I want to clear one thing. These all things can't be done in the first meeting or in the first session or in the first assessment. It can be done in the coming stages with building a good rapport, and with frequent visits only, we can just have any details about the spiritual overview. Then the next one will be the strength and comfort. Who is her comfort zone, like a god or a place or music or something. So we can just get an idea of that. Then hope. What is her hope? Then they will be having something in mind like why me. So these kind of questions comes in a person's mind. See, we have to collect the details if the person is having these kind of distresses. So next is, so what are the important areas to be assessed from the point of view of total pain? So we just discussed a lot of things like patient overview, socioeconomic overview, psychological overview, spiritual overview. So can anyone say what are the important areas to be assessed from the point of view of total pain? If you have anything to add, you can just put it in the chat box, or you can unmute and you can say. So as we discussed in the previous slide, so what are the important areas to be assessed from the point of view of total pain? As we know that total pain is a collective one. It is always related with physical, psychological, socio-economic, and spiritual problems. Okay, we'll just, I think you can just put it in the chat box. So we'll go with like what are the things needed to be. Yeah, okay. So Dr. Shivaranjani A said psychological, social, and spiritual are important. Yeah, we know it's important. Based on that case that we discussed earlier, uh, can you say what are the physical things needed to be what are the physical things you found in that case? Or what are the psychological aspects of that case? What are the things needed to be addressed, or what do you find in connection with that case?
Physical assessment of the patient first when she comes to OPD.
Yeah.
General physical examination, her, total examination, nutrition, all general examination. Then you have to assess where she lives and what kind of support system she has,
Okay.
and who is taking care of her. Is there anybody to help her? All those things, social and economic aspects, and then psychological assessment, how she is, whether she accepted that she had a problem and whether she'll be able to take care of herself, and how she is. We have to assess her psychologically.
Yeah. Okay.
And the spiritual
Right.
life, whether she's she has some community life, whether she has people to she has for her church, or what any community sort of life she has, how she's coping with the pain. When if she has nobody to take care, then what are the problems she's facing. So all these aspects we have to this thing. Also, if somebody is coming with her, then you have to find out who is the person who is accompanied, the bystander, the children, how old are they studying, are they married? So all those aspects we have to.
Yeah. Okay. Sheena, thank you so much. Yeah.
I think the full history and the physical examination will give the initial diagnosis. And with the help of the diagnosis, we'll come to know about the pain, whether it is the disease related pain or a psychological pain or anxiety pain. So depending on that, with the history and medical clinical examination, we can come to a conclusion about the pain and treat accordingly.
Yeah. Okay. That's
We
actually.
have to assess the relationship with the children and the neighbors and the surrounding people also.
Yeah.
What kind of relationship?
Okay, okay. Thank you so much for sharing that, Sheena, Shweta, and Dr. Mambati. Thank you so much. So I'll just tell you one portion of that physical portion. So then can you just tell me what are the other things? Means you can just refer it in the chat box, okay? So the physical things will be, the physical pain will be there for the patient. Then next will be fatigue will be there, and then there'll be a lack of sleep, and there'll be a body image issue, or so these are the things that comes under the physical aspects. So when you compare, when you go to the next one, like psychological aspects, then what are the things will be there? I'll tell you one. There will be isolation for the patient. So that's a psychological thing that needed to be addressed. Yeah, she may be depressed, of course. She will be depressed. Then worried about future. Yeah, mood swings. What next? Yeah, what will happen next? Okay. Okay, thank you so much. So I'll just go to the next one where you can see the whole problems. So in the first one, as I earlier said, physical pain will be there, fatigue, lack of sleep, difficulty in walking, body image issue will be there. And the next one, psychologically. isolation. The first one is because she is not talking to anyone else. She's living alone. So there will be isolation, then emotionally weak, anxiety about future, as you said earlier, unclear about her prognosis and palliative care, distress due to multiple illness. So these all are the things will be her psychological problems. These will be her worries. And then you compare, like you come to the next part, socioeconomic part. There will be strained relationship with family, unable to go for a job. So that will lead to financial problems. So financial instability is there. Then this is about house rent. We don't want to go through that because and next one, like a low accessibility to hospital, because you have seen the stone paved path there. Then the next one is absence of caregiver and support system. Like she's having hostile relationship with her family members, like children and other family members and neighbors also. So these are the things we have to check in socioeconomic part. Then the last one will be spiritual, in where extreme spiritual distress will be there. Why all these sufferings are happening to me only? Then lost faith in God, loss of connection with family, no significant person in life, like her husband passed away and children are not going to take care of her. So no significant person there, then no memorable or joyful events in life. So these are the things will come as a total pain. So the pain will be the result of these all things. It's not only the physical or the psychological or the socioeconomic or the spiritual problem. It will be an a result of these four things. Okay, so this is what I wanted to explain to everyone, and your points are very valuable, and what you said is exactly right. Like these whole things are related to each other, and this will make that person suffer more. Okay, so next one is possible social impacts that will happen to that person's disease and that will happen to the patient. First one will be social isolation, because she's not going anywhere. She is staying in that house only. So if anything needed, then a hospital or a person from the palliative care goes to her house. So that is there. So she's not connected with other persons. So social isolation will be there. So the next one will be dependency. She has to depend to other persons for her day-to-day things. And she have to ask for others. Then financial instability, then lack of social support, because they have a house in a steep position in a hilly area. So there will be a reachability issues will be there. Then that leads to lack of social support. Then the next will be debts. If the person is having any previous debts or something, any loans or things, then there will be problems related to that. Then loss of work. If she is a person who was the breadwinner for the family, then due to her illness, it will get affected. Then interpersonal issues and inadequate facilities. So these are the possible social impacts that will happen to that person in that distress. And then possible psychological impacts will be, as we earlier mentioned, like feelings of shock, uncertainty, hopelessness, anticipatory grief, poor insight about the illness, anxiety, once more, then suicidal ideation or wanting to hasten death. This is an important thing. Suicidal ideation will be there. So if there is no one to support, if she is unable to do something with her own, suicidal ideation comes, and this is a major problem. So we have to assess that in the psychosocial care, and then for coping with the illness. Like she will not be able to take medicines at the exact time. she'll be in a mental state like, why should I take it? So these kind of things will be there. And psychosocial and spiritual suffering is real, but can be difficult to recognize and treat. So, and often this can be manifested as physical complaints. So that's why I said earlier, total pain is a complete package. It's not only physical, it's related with the whole things that surround a person. So in Pallium India, so what we do is we take interventions based upon our assessment. So first one will be providing information for the patient. So what is their diagnosis and all, what needed to be happened, means what are the next steps to treatment. And the next one will be liaising, relating them with or connecting them with any other resources or something, then facilitating that resources, then rehabilitation works, then bereavement support. It's not in every cases. If there is a death happens, and we will continue with the support, like bereavement support. We will visit the person's home, and it is a relievement. It is a relief for that family too. So bereavement support will be there. Then follow-ups. In timely intervals, there will be follow-ups, and then supportive counseling. If there is any family members or that patient needs any family counseling, supportive counseling, we will be there for that support. Then psychoeducation will be there. So these are the things we do in interventions. And this is an extra part. This is not. This is actually related to this whole thing. And I want to just mention, like, what are the vulnerable populations? Who are them? Okay. So the person who is living, elderly without support, single parent, multiple patients in family, then victims of gender issues like domestic violence, physical, verbal, psychological, or sexual harassment, then individuals with mental health issues, individuals with suicidal ideations, socially isolated persons, substances users in family, individual in extreme poverty, like lack of food, water, shelter, etc. So these are the vulnerable populations. Those who can means those whom we can find in the rural areas of anywhere. So we have to take care of that persons. So in addition to that, I'll just mention one more thing about the greatest supporters for the patient is caregiver. So as said in that sentence, like Rosalind Carter depicts that there are only 4 kinds of people in the world. Those who have been caregivers in the past, those who are currently caregivers right now, those who will be caregivers in future, and those who will need a caregiver. Every person should learn from that word. Like in our younger age, we will be very we don't need anyone's help, but in a distress, we will need someone's help to just move or do anything. So a caregiver is a person who does that thing for you without any need, means without any need or something. They don't need anything. They do it with the passion or with the love. So respect those individuals and acknowledge their complex role. So never dehumanize them by calling them bystander. So this is the part of caregiver. Then this is an important question in our setting, like in our palliative care. What do I need to know about you to help you better? So this is what we ask them when they get very attached to us, or after making a good rapport with them. So what do I need to know about you to help you better? So with that question, we came across a person. These pictures were taken with the consent of patient and caregiver. Okay. So in this picture, you can see a person who is bedbound. Actually, he is paraplegic. So it was their wedding anniversary. and his wish was to celebrate that, but he didn't ask us to do that. During a session, we get to know that the wedding anniversary is coming, and we just prepared a small cake, and we just cut the cake with her wife, and you can see his smile there. So these kind of things needed to be done to satisfy their their emotions, actually. So this is the first one, what we do here. And the next one is social support. Like what we do here is we support the family, not only clinically, we support them in another ways, like social support to the patient and the family members during treatment and after bereavement is an essential part of palliative care activities. So these kind of things we do very oftenly, and that includes education support, food kit for those who don't have food, and then vocational rehabilitation, and travel aid for whom they're financially unstable, then physical aid. Like if they are unable to have one physical aid like walker, wheelchair, or anything, so we will support them, not give them everything they need. We will give them with the help of any donation or anything, kind of that. And we will just refer them to any other sources where they can get it very freely. So the next one is vocational rehabilitation. That means to stabilize the family's income, to encourage the family to become self-dependent, financial security of the family, and to engage the family. So these are the things we do, and you can see it in the next one. You can see in the first picture, there is a person, there is a mother who is supported by goat rearing. The next one is candle making. Then the next one is sewing machine was given to them. Then the last one is umbrella making. So these whole things are still continuing. So they are surviving with the help of this. And next is support for children, as I mentioned earlier, like education or emotional support. So these are the kids. These are not all the not the exact amount of kids. This is a small group of kids. Oftenly we have around 200 plus students in 1 year. Those whom we support, and we'll be having a small meeting with them, and we will be having a huge program called as Kuttikootam in every year. So where they came to a place and gather together. So this is an external support for them. Then the last one I want to say is, do remember to evaluate our interventions, because sometimes in the case of vocational rehabilitation, it will not be going through what we thought. So we have to just evaluate our interventions. Then the next one will be assess how the patients and families are benefited, because we only have 2 goats and they need 2 cows. So what will be the benefit? Their needed to be satisfied. So we have to think about that and assess how they are benefited. Then assessments have to be revised and updated, because what we have done in 4 years ago will not be done today. So we have to just revise it and update it. Then reach out for help if needed. If I'm not able to do anything, I'll be just asking to my senior or my junior. So that is the thing there. So if anything needed, we have to ask for help. Then there is an art and science in psychosocial care, just as in medicine, because everything is related with one another. And so this is the end of the session. And I want to say only one word, like by Mahatma Gandhi: the difference between what you do and what you are capable of doing will solve most of the world's problems. So, so this is the session about it. And if you have anything in your mind, you can just ask me through the chat box. I think next will be a case presentation. Okay.
So, thank you, Sarath. Dr. Radha,
Thank you very much, Sarath. And sorry for pronouncing your name. See, if you would like to be called as Sarath, that is what we will do. Okay. And next thing is that couple of things which I would love to say is the Rosalind statement, what you said, that is totally true. And I'm very, very proud of you to bravely say that when you're young, everyone thinks I can do everything. I don't need anyone on earth. Okay, that will transform. Not everyone are like that, Sharath. There are some golden gems who, when they are young, they will say, I know what I am and who I am, and will be willing to help. You may be one of them. So you have come into this profession at a younger age. And I had an acquaintance when I was in Adyar also with a person, a social worker who was doing his PhD. He used to give me maximum help. Anything I need, I will call him and get it done.
Yeah.
So good things that all of us have to take. These are all phases of life. If I can be of any help, that's something we all have to develop. As Dr. Biju Raghavan said, we all have to develop smile. I think we also have to develop this attitude. And I think everyone will agree with me in that. And other things are that every aspect, as you've said, no, psychological, social, spiritual, everything has, you can't differentiate or separate them. If you separate them only, you don't achieve benefit or treatment of total pain. So as we always say now, multimodal, multidisciplinary, that is how success could be achieved. And you have also mentioned about all the aspects of how you could reach out. This is what I keep on telling everyone. And next thing, don't feel ashamed that you're unable to do. One person cannot do everything. Accept that bravely. It's nothing like that. See, one person may specialize in one particular thing. If without Sharath's help, I will not be a successful palliative care physician. And I will not hesitate to ask Sarath. I will ask Sarath because the patient is going to get benefited. Their me-I doesn't work. Okay? We are all going to look at ultimately patient's best interest. So that is what I would say. If anyone has some burning question regarding this talk, we could just have a couple of minutes maybe, and then go on to case discussion. Or if everyone feels okay, we can go into case discussion straight away too. Either way is fine. I thought if someone wants to ask something immediately, please feel free to either unmute and ask or type in the chat box.
We can move to the case presentation right now.
Yes, Mr. Priya, we'll go ahead with that.
Patanjali?
Am I audible?
Yes, doctor.
Okay. Before I begin my presentation, I would just like to thank Mr. Sarath for a wonderful presentation and for giving us a very in-depth understanding. Definitely, as clinicians, we're looking at the clinical aspect of it, but this is something that was very informative and knowledgeable. So thank you so much, Mr. Sarath. Also, I would like to thank Pallium India for giving this opportunity to do the presentation. So I'll just quickly go ahead. So we're looking at the case of a gentlewoman who was 70 years old. She came in with the diagnosis of carcinoma right breast, stage 4, with staging of P4P, N1 and M1. She had bilateral lung metastasis with minimal pleural effusion, multiple vertebral, iliac and femoral metastasis, and also was a known case of hypertension. So presenting complaints, right breast lump, she observed there was an increasing in size, a small right breast lump since the year 2021 from the month of December. She had lumbar region pain for 4 months, difficulty in ambulation due to pain, breathlessness occasionally, and she was diagnosed with right breast CA with METS in July of 2022. She was admitted to our Center for Supportive Palliative Care. Now, the history of present illness. January 2020, according to her, the size of the breast lump initially was mustard size. It was painful. In her language, it was a pimple which she had noted in the right breast with no associated symptoms. She left it unattended and moved to the city to live with her son post her husband's death. Interim, the size of the lump was found to be increasing with no consult made for the same. Jump fast forward to March 2022. Incidental visit to hospital due to an alleged fall at home in the village. Right breast mass observed by relative and was taken for the further evaluation. Provisional diagnosis for breast CA was made and she was referred for further evaluation. Again, from March to June, there was no visit to the hospital. And in the history part, in June 2022, she had visited the medical facility in the city, now where she was with her son. She underwent evaluation, and at this point, she was diagnosed with carcinoma right breast with T4B N1 and M1, referred for radiotherapy, surgical resection. However, the patient was not willing to undergo any active treatment modalities, hence she deferred the admission. Now, on examination, I've just written the pertinent positives from the examination that we had carried out here. So the right breast mass was around 8 centimeter by 10 centimeter, firm with irregular border, mobile, and redness was noted. Right axillary lymphadenopathy, right supraclavicular lymphadenopathy, pleural frictional rub, right more than left. There was warmth and tenderness in the lumbar region. Just to quickly add in, at the time of admission to our care center, she had strictly denied to go ahead with any of the investigations. So the investigation that we had got in was the next slide. So she had come in with her PET scan reports, which was the only investigation that was available with us, and she had not allowed for any other diagnostic. So these were the findings. In the PET, she was found to have malignant neoplasia with infiltration of the skin right breast, irregular nodular thickening of the left pleura with metastatic deposits, metastasis in the right lung upper and middle lobe, mediastatic lymphadenopathy, and multiple osseous lesions. In the treatment aspect of it, we had overall treated, so she was on these treatments, some of this which we were able to add and some of which she had got from her previous admission in June 2022. So she was on painkillers, PPI, multivitamins and food supplement, appetite stimulant, conservative management with regards to ice pack, SOS, music therapy, dance therapy, art therapy, professional psychological counseling session, and Ayurveda massages, Shirodhara for her stressors. So the psychosocial aspect on in-depth discussion with Ms. X, we found out she had not accepted the diagnosis. So she used to recurrently question to multiple people or multiple doctors who visited her, "Are you sure what I have is cancer?" In terms of culture, on asking that, when we tried to, dig into the questions of why she would not go ahead for the mastectomy, the surgical resection part of it, she said in her culture of where she comes from, the loss of gender identity with the body image issue in case of the surgical resection. So she did not want to go against that. In terms of spirituality, she kept questioning, why did God punish me and my husband? He also had a very strong feeling that, her husband passing away and her sickness setting in were very close in proximity. So it was almost like a spiritual punishment that they both were going through. Family, she lived with her husband in southern village in Tamil Nadu. So she lost her husband 2 years back, and children are settled in different cities. So children were unable to spend time with her. And now that she knows that she is on the verge of passing away, she wanted to spend time with the children who were the only living part of her family now, with her to her content, but the children are not able to pass time with her because they are in respective cities taking care of their own lives at this point. So they are not able to spend time with her up to her content. Disbelief on modern medicine. So in her understanding, when her husband also passed away 2 years back, she felt that the medicine or modern medicine could not diagnose it or help him in the hospital, and he passed away in the hospital. Similarly, whatever she is going through, the modern medicine cannot or will not help her. loneliness and no social interaction. Post passing away of her husband, she was living alone in the village. So she felt that there was no one to hear her out with all of her thoughts in her head. She felt trapped within her thoughts about passing away onto the next realm. Loss of meaning of life. So identity of living with progressive terminal illness. She did not understand why or how she wanted to live further anymore. She also on recurrent visits to her, what she would also request was to end her misery. She kept saying that I have nothing more to live anymore. Would you please medically help me to end my life? So we were able to understand that she also had suicidal tendencies. Next slide. So these were the medication that she had come in with. I just wanted to clarify one more thing. So tap tramadol was prescribed by the doctor initially for her on and off lumbar pain. Since she was not responding to that, the buprenorphine patch had started, with which she had good relief. Apart from which, the regular hypertensive medications, multivitamins, and an appetite stimulant was being given to her, along with other protein supplements for her overall nutritional part. Next. So the case that I just brought forward, the concerns that came up to me at least was the symptomatic, or is the symptomatic management adequate? Are we able to holistically guide and counsel her through these days? Are we doing enough to eliminate her social isolation? And how efficient is the multimodal team approach to her in this state? So in summary, patient was well until 1 year back, progression of disease over 1 year after husband's death, ignoring symptoms and unwilling to take further medical treatment due to disbelief in modern medicine and cultural reasons, currently receiving pain management with holistic psychosocial counseling. So discussion points, I just divided into two perspectives. So in terms of clinical, what I understood was to communicate of what is happening is natural, or educate symptomatic management, providing alternatives to drug therapy or restraints by understanding and communicating, not just to the patient, but also to the staff who are handling her, so as to how we have to reciprocate to her, so that her needs are met, both physical and psychological, finding options which most meet the physical and the emotional needs for her from the clinical perspective. Non-clinical perspective, explain that it is all right to cry, tears are normal and show caring, encourage expressions of affection, a continuum of adding value and quality to life in the remaining days of the patient, listen to her last wishes and regrets of the last wishes and regrets, meeting the needs of the patients and the relatives who are grieving or caring for her, to be present with the resident and the family if they want support. Just wanted to put in one word also forward. So in terms of discussion points, I was not very clear in terms of if we had to put points for us to discuss. So I just put forward my understanding of what pointers we could, discuss, or I could understand from our discussion in terms of the psychosocial aspects. So next slide. While I was making the PPT, I was really moved by Cicely Saunders, this element of what she said. You matter because you matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also to live until you die. So with this, what I also understood was clinically was not just important, but the whole approach of how Mr. Sarath explained the total pain needs to be delivered. And we will definitely need to reach out to the other aspects apart from the clinical to also to give the whole answer to their whole pain. So that would be it from my side. Thank you.
Thank you very, very much, Dr. Renu. Exactly, you brought forth a case which has got all the aspects. An individual, that person, more than the patient, has to be valued. And her wishes, we always say, anyone, if it was I or you, we would love our wishes to be respected. That is what we all have to learn. They may not like something. See, for example, not having faith in modern medicine is nothing wrong. That is her faith or her belief. So that is what we always have to slowly develop and cultivate, that just respecting another person. If she accepts us, then we'll be very happy. If she doesn't accept our view, we cannot be unhappy. That's the only thing, slowly to be developed, and take her way. And then, and as the whole palliative care element is same what you brought up today, is giving the respect to anyone and everyone all through their life, even at death, to give dignity to the patient, dignity to the family, respecting them and helping them. That's what, see, death is something inevitable. Even if you try level best, you're not going to win. So no point trying against something where you will never win. So accepting, understanding, and explaining is very important. And that's what, and then we'll go into the individual psychological aspects. Yeah, very good way of putting it across, like clinical and non-clinical, fine. Like each one of us look at it differently. And I would say, I would leave it open for everyone to put their views, and then we will take it from there. As usual, either you all can type in the chat or unmute and speak. Sarath, if you want to add on anything specifically before discussion, please go ahead.
Actually, what we discussed in the previous session and with the case presentation, it's almost same. So
Exactly.
yeah, so it's the participants' role now.
Yes, that's all. So we will leave it open for them either to type or to unmute and ask. We'll go, I would say we'll go ahead with as the questions are, no? Whether communication, what is happening, was that adequately told to her, and then adequate symptomatic management. Like the point 1 and 2, what would everyone feel? What would everyone feel, whether it was adequate, or if not, what are you going to do differently?
In my opinion, this patient doesn't want any surgery or any treatment, definitely. But having a mass, such a big mass on her breast, I mean, if she may live for a longer time, and the whole mass may ulcerate, and it will cause a lot of such problems. So maybe counsel her to do at least removal of mass or something, radiation, palliative radiation or something, we can suggest to her, counsel her. I think very important, counseling, because we have heard of patients coming with very bad ulcerated mass because they didn't, they just kept secret about the mass. So at least we can help this patient.
Yes, truly. Well, as you have said, no, we can explain to them, but still the choice will be hers. We can say in our clinical experience, for having worked so long, this is what generally happens. So if then we can give her time. You can go back, think about it, and come back to us. And then we can see. So, and one more thing, as Sarath mentioned today, everything will not happen in the first meeting.
Yes.
I have been stressing that again and again, many times during all of our presentation. That is one thing, like important take home, I would say, and especially psychological, social, and these type of issues, because we all have something called, we don't want to reveal. That's human tendency. Okay. So we have to give time for the person to open up. Yeah. Okay. So we could suggest, and especially palliative radiotherapy is something we could explain. Well, Dr. In, do you want to say something?
Actually, ma'am, just wanted to say that the previous slide, Ms. Shreepriya, the previous slide, the one before that. So these were the questions that I thought we could just, maybe discuss together.
Yes. You've got all the points there where whatever queries are there could come up. That's what we could explain to the patient. What are the pros and cons, and still leave the decision to her. I will never force anyone. That is autonomy. Okay. It's our responsibility to explain. And then finally, respect the patient's decision. Okay, that is what, even in our communication slide we saw, we cannot assume and we cannot force. Both, so it is our responsibility to explain. And as in the discussion we had now, we could convey to her that ulceration or fungation, all those can happen, but there's no hard and fast. But we could explain to her what are the other modes could be tried and get her for counseling, because many times to accept, and with her history that she is of the opinion that she is by herself, she's alone, and many loneliness, helplessness, so many things are there. We have to consider everything and give appropriate management options.
If
Go ahead.
possible, her children should also be, counseled. They should be told the consequences of,
Yes,
not
yes.
doing it properly.
Patient counseling, that is, it has to be done separately.
Yeah.
When there is conflict like this, it's better not to get both of them. Sarath will totally agree with me. You will have to have their counseling separately, patient counseling separately, and then find out when they are in an ideal situation. Sarath, I would leave that to you. It would be nice if you could explain from that point of view.
Yeah, surely. Ma'am, actually, I want to add one more thing. There is a point like multimodal team approach. Actually, it's the core of this discussion.
Yes.
You're saying in the perspective of a doctor, and a nurse is having their own feelings, and families having that, and social workers having their own feelings. So, as a holistic approach, when we come to one point, like the care should be improved and the details should be given to her in a proper way that she can agree with that. So as Sheena ma'am said, the children should be taught well. They need a separate session. Like also, I want to mention one more thing, like spiritual guide. If she's having any person in her mind as a person whom she can talk or whom she is very attached to, or a person who can guide her this is what needed, or if there is such a person there, then we have to find it, in my opinion. And if the children are not very they're not very good in terms with the mother, then we have to educate them. uh, After taking so much sessions, it's not a problem. It's not a problem, actually. We can invest our time into that because it will lead us to the care of that mother, actually. So I will definitely say that it's a part of everyone, and now it comes to my way, actually, and part of a social worker and a counselor's way. Like we have to educate them with what are the consequences that are going to happen if she is okay with that conversation. We will ask them, ask her, like, if you're okay with the conversation, then we will go with. Otherwise, if there is anyone to convince her, then we will go by that way. So that's what I think.
Radha ma'am,
Definitely true, Sarath. She will have someone with whom she will open herself. Maybe that person she's not able to access or something. So we have to give some time. Even that she may not really reveal in the first meeting.
Sure.
Give some time for her and tell her, take your time. If you have someone in your mind, because it will be nice for you so that you don't have something like unfinished. If you give that option to her, she will definitely open up. And that person may be able to link her and the children too. We don't know, because this is all like a stab in the dark, we say. We are all assuming many things. We may get some simple solution also out of it, but we have to try and see. Always worth doing that. And sometimes there are many studies which show that spiritual people who have strong beliefs in spirituality, they will have a better outlook. So from spiritual perspective also, she may be willing to reveal many things to a church. Like, see, you mentioned that she's, it all depends what spiritual link
Yes.
she has. And we can get someone from that, whatever practice she follows, and then see in that perspective also. Meaning of life, like why this to me and all that can be answered from spiritual point of view too.
Yes, ma'am.
And there are many studies which have shown, and there is a strong link to spirituality and palliative care.
Yes. And it's a broad term too.
Yes, no, I always say, if there is time, I'll tell. Religion and spirituality are two train tracks. They're two different things. People have to understand what is religion and what is spirituality. Just a short thing, I would say religion in one, like few words. Religion is just customs and practices. That's what is religion. Whereas spirituality is what is life, meaning of life. That is what is spirituality. So don't ever try to link these two. Then you're wrongly doing it. That's like bird's eye view opinion. That you can go into both depth in great detail. Just a broad compare contrast, I have said. Anything else in the chat? I don't think so.
No, actually, I think everyone is yeah. Go on, ma'am.
Agreement is in agreement with what we are telling. I'm also hoping so. Just I'm going to read what is there. Counseling of the family members to visit the patient as she wanted to spend time. Yes, that is what we have discussed.
Yeah.
From these main concerns, have we looked into, are we able to holistically guide and counsel? Are we doing enough to eliminate social isolation? That, as we have mentioned, we have to get her involved with other things. And multimodal team approach is what he has, Sarath has mentioned. And I think in most of the centers, oncology or psycho-oncology team work with palliative care. And we also have physiotherapists and dietitians also working with us. Yes. And that is how it works. And there are few modes, as Sarath mentioned. I would like to say, in some places you meet each, like the patient will meet each one of them separately. In some centers, they also do like all of them meet the patient in one place. These are different approach. They're all done according to the individual situation and individual practice, individual availability of resources. Everything has to be considered in these. And whatever each center practices, that's the best, because they know what they can get. So that's what I would say. Anybody else, anything you would want to bring up? Palliative care, holistic, compassionate, comprehensive, family-centered care, catering to psychological, emotional, social, spiritual, religious needs of the patient. Exactly true. Dr. Akshita Agarwal. Yes, totally true, dear. That is what it is.
Also, I want to add one more thing. As a doctor, you will be able to, a person will be able to do clinical things. And also, a doctor, a nurse, or a social worker, or any person can be a human being. So they can understand the feelings or what they are trying to convey. So with the help of like a team meeting or by a multimodal team approach, when you can share that exact things with other persons, then you can get into a proper plan and you can execute it and you can excel in it. So that's what I think.
Exactly, Sarath. That is team working.
Yeah.
I always say there is no I in team.
Yeah.
So if you practice that there is no I in team, you will only be successful. So being willing, that's team working is what is heading everywhere. And by team working, we will be able to succeed. Because there, what happens, whatever deficiencies are there, all deficiencies are fulfilled. Yes. So when all deficiencies are fulfilled, you're going to be successful finally. Okay, importance of healthcare providers to communicate effectively, not only with patients, but also with the family members and among ourselves, sharing of information. Yes, true. Importance of multidisciplinary meets, role of allied health professionals and volunteers. Definitely. Each one willing to help each other. If you have these volunteers and NGOs, social and financial needs will also be met. If we are all happy with all the discussion so far, just one thing what I had mentioned in our last session about this query with metronidazole, I had mentioned that I will have a look. I have had some look, okay, with some review with literature, and there is no clear evidence that metronidazole carcinogenic effects. They are said to be found more in rats and mice. For that only data is there. For human beings, there is no clear-cut data, okay, because only from what I have read so far, I could find is when it is used in generally beneficial effects are what is mentioned. They have done plenty of study control groups with metronidazole, another group without metronidazole, both for malodor and for healing of ulcers and things. They have had a positive response, like in fact, statistically significant response. Regarding the carcinogenic effect, from all these studies, what they say is when it is used very high dose for very long period of time, even for that, there is no strong data which is statistically significant. So with all this in mind, I would say from all the practices that we have seen, the amount of dosage that is used is not harmful. That is what, because there is no clear cut. They have even finally what I read 2020, there are many data and papers from 2002 to 2018, but some only more than that. What they say is because there's not been so much research into very high dose. There are a couple of papers, but not much, like statistically significant number in groups are not there to say that it is carcinogenic. So with all this in mind, no, we can use comfortably, because I'm very careful in what words I'm using, because that shouldn't, because as I've seen, no, you see when you treat with that and see the patients and the amount of ulcer healing, you would say that it is beneficial. So it is each one's take to carry on, and with always I say risk benefit ratio, the benefit being better, it should be okay. And as there is no clear-cut data to say that in humans it is carcinogenic in the dosage and duration used. That is what I could update. I will still see if I could find anything more.
Thank you, ma'am. I was the one who asked that question.
Yes.
But what you said, I have read it. Yeah, it is. Yeah, it is carcinogenic only in rats and mice. They have done the studies. It has not been statistically no evidence proved in human beings. But you have a vast experience, so I wanted to find out from you.
That's all. See, I have used it for a long time, and many people ask, because even if you see in the metronidazole ointment, that will have that statement. So even some of my family members have asked me, you're telling this, but it has this statement. I say, I used to tell the same thing. I've been telling this for nearly 20 years. So it's going on. So I don't think it is that harmful.
Thank you, ma'am.
Welcome.
Yeah.
Okay, then hope all of you are up to date with all the information and things. And I will big thank you to Sarath, and I'll hand over to Sri Priya.
Thank you, Dr. Radha. Thank you, Mr. Sarath. Thank you for joining us at this time of the day and giving a wonderful insight on the different psychosocial aspects and giving it another perspective. I hope that everyone would have got at least one takeaway message from today's session. So with that positive note, this is Sri Priya along with Dr. Radha Venkateshan and Mr. Sarath K signing off from the Tips Eco Hub. See you in the next session with another interesting topic and yet another eminent faculty. Till then, everyone, take care, be safe. Bye-bye.